Okay, so the next one in the range is the 2.4 kilo baby. So this is a standard £5, £6 baby. The main things about this particular size of baby is both the realism, but also the way, and I'm hoping you can see this quite well, but the way that the limbs actually move. Now we do one of these babies with a clicky hip or DDH assessment baby, which has the clicky hip at the bottom end and the full ALS stuff at the top end. The thing about the movement with all of the Lifecast babies is we're trying to get as close to real as we can. So if I was wanting to teach one of the clinicians how to cannulate as an example, then I would hope that I would be able to bring the hand over just like so and bring up the vessels that you can see on the hand. And the problem with the plastic mannequins is they just don't allow us to do these sort of demonstrations to our students of what they should or shouldn't be doing. With this one, we've got nasal access, we can intubate, and we've got cord access. We've also got tibial interosseous, so we again have the option. And I know that most IOs are contraindicated in under 3 kilos. We have built it into the 2.4 kilo baby, just so that it's there for people if that's what they want to do as part of a scenario, acknowledging that the devices are quite often not allowed in the under 3 kilo baby. I'm going to now show you how we use the Monivent system, which I've got besides me, which will show you how on all of the babies we're able to demonstrate the ventilation and our ability really to use a bag and mask or a T-piece. I'm using the supplied Monivent mask, but you can use your own. If you've got an adapter like this, which we supply, then you can put a dongle in and use your normal either T-piece at the top and your own masks underneath. So to use this device, first thing I'm going to do is I'm going to put in 2.4 kilograms, which is the weight of the baby. I'm going to take out a dongle, just like so, from the recharger, and I just attach it into the mask. The next thing I do is obviously take my bag and mask like so, make sure it's all connected up, and then hopefully what you can see as I start to ventilate is that the dongle is sending messages across to the iPad of how much each of my ventilations is worth, and hopefully you can see the numbers changing, and you can see that I'm doing things in a reasonably realistic manner. So the numbers that I've got on the screen, pressures of around 20, respiratory rate of about 43 that I was bagging at, and we can see some leakage there at about 20. If I overventilate or underventilate, so let's put one in that's a little bit too small. So you can see again it's registered 2 mils per kilogram. It's not overly happy about that. But similarly, as I build up, you'll notice I get a little green light on here, which we can turn on or off, but I've got a visual clue on the dongle as to how well I'm doing. And then if I really overventilate and get carried away, and you can hear the pop-off valve going, you can see that I was up to 10 to 12, and I was also way over the 42. And you could hear the pop-off valve going on the bag and mask. So there's a lot of education we can do with people, both about mask selection and holding of masks, but also around the whole area of the pop-off valve and how it would normally get used. We're big fans of Monivent, and we use Monivent when we're designing a lot of the babies to try and make sure that we've got realistic pressures in all of our mannequins. I'll move on again and we'll just talk about a few slightly larger babies and children. So this one here, he's a 10-pound baby, or around about sort of 4.5 kilograms. He has nasal access, orally intubatable. Obviously there's no cord because this guy's about 3 months old, so we would have hoped that that would have gone. He's got tibial interosseous, and also he's suitable for chest compression. He is the real weight. He is genuinely 10 pounds, and you can see hopefully quite nicely just how floppy that makes him. So it's your standard ALS baby, but at the real weight, which creates challenges of its own. If I move up in size again, we're talking about a toddler. So this is the 3-year-old. Again, we have nasal access, we're orally intubatable and ventilatable. We've got tibial interosseous, and again, I should have said with the previous one, we can also cannulate. You just won't get flashback from the Lifecast because they're really designed for whole systems integration. We do a couple of unusual versions of the toddler now, one specifically for drowning, which will create foam and bubbling from the lung space. And we also do a thoracic trauma version where, again, when you're going in to intubate, as an example, you would see blood coming up through the trachea from a rupture to the lung itself, or damage to the lung itself. The toddler weighs in around about 14 kilograms, so he is truly age 3. And again, even skills such as choking are actually quite difficult to deal with when you've got a child of this weight. You wouldn't be able to hold him for very long, and your techniques need to be pretty good actually to be able to manage the weight side of a mannequin such as that. Moving up one last stage is we have the standard child. So we're talking about a child now, age around 8 or 9. This is a Lifecast of a real girl called Katie. And she was turned into a mannequin a few years ago. Specifically, she was used originally for a movie. We've got nasal access, orally intubatable, obviously chest compressionable. You've got the same ability to do IVs, and again, we've got IO pods in the legs. She's a standard, what we'll call a standard ALS mannequin, but you can see just how realistic she is. And that realism, even down to things such as earrings, on the adults we'll sometimes do a nose stud or other piercings, but you can see just how realistic she is from a skin tone point of view with freckles and everything else. To bring all of the mannequins to life, one of the areas that we quite often get questioned about is obviously things such as physiology. So in front of me I've got the iSimulate device, and this is what we use as a team to help us to create realistic scenarios. So it's basically one iPad which is controlling what happens on the screen of another iPad. So in my iPad, I've chosen the monitor that I want the students to start their scenario with. In this case, I'll pick the LifePak 15. I can turn the device on, and I can choose when the students actually see things appearing on the screen. So as an example, if they apply the SATS probe first onto the mannequin, then I can turn on the saturations. And you can see that we've got saturations of 91 and a heart rate of 98. The next thing they may take out of the bag, well, maybe they'll do a blood pressure next. So I've set a limit for blood pressures, and on the device, it will make the usual noise associated with taking a blood pressure. And it will do it in real time, which is also a big advantage. Then they may be saying, okay, next thing I'm going to do is I'm going to apply my 12 leads, or I'll start with my 3 leads. So they put their 3 leads on ECG on, and then they'll move on and do the rest of their 12 leads as a good example of how this works. Eventually, hopefully, they may build up to adding on end-tidal CO2, in which case, again, I can give them end-tidal CO2s, respiratory rates, etc. Now, anything that I choose to do on my screen, so such as I'm going to brady the child down, I'm going to desaturate them even more, I'll increase, or in fact I'll decrease the respiratory rate, and I'll ask that change to take just 20 seconds. I'll push go, and the child will now naturally desaturate over the next 20 seconds. If the learners choose to do things such as 12 leads, then it will work just like the real device would. And it will give them a 12 lead based on the rate that we had at that time, with all of the morphologies that I'd previously chosen. So we're big fans of the iSimulate. As I say, we can choose between different monitors. So if we've got a Philips IntelliView, then I can just swap it over to be an ITU type monitor. We like the way that we're able to add on layers of complexity to develop our learners more and more and more. And I think really that's one of the very important parts with all of the iSimulate tool, is just how far we can go in terms of adding realism into our sims. So what we've shown you is a range of paediatric and neonatal babies and children, and then adding the Monivent on to give us that respiratory assessment and understanding how well people are using the respiratory tools that we give them, and then using our Simulate to unpick their knowledge of the physiology associated with patient assessment or resuscitation. We hope that we've given you a brief understanding of what we're all about, and thank you for your time.